So dear Proshia, this is one of the important topics to be discussed. Precision hypertension management, integrating the phenotypes, comorbidities and different therapeutic interventions to treat these individuals. So you all know the definition of the hypertension. When the systolic is more than 140 and the diastolic more than 90, we call them as an hypertension in the Indian population, but not in American. So in America, so when the systolic is more than 130 and the diastolic is more than 80, they are considering them as hypertensives. Whereas the European countries, like our Indian standards, 140 by 90. But whether in America or in India or in Europe, our goal is the same. What is our goal? Blood pressure less than 130 by 80. So that should be our goal of achieving in all hypertensive individuals. But it's very easy to say, but very, very difficult to reach this figure of 130 by 80. So every visit, their blood pressure will be 150 by 100 or 140 by 90 or 160 by 100, like that. Very few people will come with us on regular therapy with a BP of less than 130 by 80. Maybe 10%, maybe 15%, not more than 20%. Okay? So you have very high responsibility, high index of responsibility for all of you that to diagnose the hypertensives much early, to keep them on good antihypertensive medications much early, and of course the follow-up is very, very important, and you have to keep their goal of their blood pressure less than 130 by 80 to give them a good quality of the life and prolong their life. Otherwise, these hypertensive individuals will enter into the cardiac ICUs with acute myocardial infarctions or acute heart failure or tachyarrhythmias, or they may enter into the neuro ICUs with cerebral strokes, either ischemic strokes or hemorrhagic strokes, or they may enter into the nephrologists with acute kidney injury or chronic kidney disease. So these are the very, very common. Sometimes they also go to the retina surgeons for your hypertensive retinopathy, grade 4 or grade 3, Kitt-Wegener's-Bakker's classification, your papilledema, etc. So all of us, responsibility is, please don't neglect hypertension. Very common disease in the society. At the same time, even the physicians are also not paying much attention for the management of the hypertension. So you are all agree with me that this is the single pill is available in India. So on the day one, if your diagnosis is hypertension, better to start with combination therapy. The days of monotherapy has gone. Most of our individuals, they need a combination drug therapy for an hypertension. Monotherapy, very, very small percentage of the population. See, consider the monotherapy in low risk grade 1 hypertension. What is grade 1 hypertension? Systolic 140 to 159, diastolic 90 to 99. So what is the hypertension people coming to you? More than 160, more than 100. They are in stage 2. So in the stage 2, they need a combination drug therapy. Monotherapy is needed for the grade 1. Very few people we see with the grade 1. That too, grade 1, who low risk individuals. But most of the Indians are at either the moderate risk or the high risk. Hypertension with the diabetes, are they low risk or high risk? High risk. Hypertension with other comorbidities, as our friend saying that hypertension plus CAD, hypertension with CKD, hypertension with heart failure, hypertension with obesity, hypertension with the dyslipidemia, they are all at high risk. So all the high risk individuals, they need monotherapy or dual therapy, dual or a triple or quadruple, a combination therapy. So that is your motto. So whenever you start with a monotherapy, you ask yourself whether it is a low risk individual or at a high risk individual. All the high risk individuals, they need dual therapy or the triple therapy. So what is the initial agent of the choice for you? It is always ACE or ARB plus calcium channel blockers or ACE or ARB plus diuretic, your choice. You may start with telmisartan with hydrochlorothiazide or chlorothalidone, or you may start with telmisartan with amlodipine or cilindipine. Okay? So in a diuretics, usually we use not the loop diuretics at this juncture. We use loop diuretics when the GFR is less than 30. That means the fellow is in the CKD. When the creatinine level is more than 3 or the 4, then if you calculate the GFR, that will be less than the 30. In the less than the 30, you stop using the hydrochlorothiazide or chlorothalidone, start using furosemide or the torsemide or the loop diuretics. So here the diuretic means mostly it is a thiazide diuretic or thiazide-like diuretic. What you mean by thiazide diuretic? Your hydrochlorothiazide or chlorothalidone. What you mean by thiazide-like diuretic? Indapamide. Metabolically friendly diuretic. Most of the diuretics, they cause uricemia, hyperuricemia, they cause dyslipidemia, they increase the blood sugar levels, so they disturb the electrolytes. So these are the common side effects of the diuretics, not seen with your metabolically friendly diuretic like indapamide. So this is your ARB plus CCBM. That is the drug 1 starting. So after 2 months or the 3 months, the blood pressure is 140/90. So what to do? In spite of the first pill, still the blood pressure is 140/90. You want to escalate the drug or you want to continue the same drug? Escalate. Because what is your goal? Good. Your goal is less than 130/80. You did reach your goal. So what to do? To escalate the drug. So go to the second one. So that is again the single pill is available. 3 drugs. Use telmisartan plus either amlodipine or cilindipine plus either hydrochlorothiazide or chlorothalidone. Your Telma Trio or Telma AMH or Telmed AH. Okay. So such drugs are there. So the 3 drugs combination. Then after 2 months or the 3 months, the blood pressure is 140/90. What to do? Continue or escalate? Again escalate, because your goal is 130/80. Your goal is 130, so escalate. So now you add some other drug. The one pill contains the 3 drugs. You don't have the drugs which contain the 4 drugs in a single pill. So then you add second drug. So that second drug may be a beta blocker, it could be an alpha blocker, could be a loop diuretic, could be a spironolactone, could be a central acting drug like arcamine. So that depends on the situation. So for example, the fellow is in edematous conditions. So which drug you prescribe in such individuals? Maybe your loop diuretics. No edema, all the 3 drugs are there, still the BP is very high, then you can add the spironolactone also. And the creatinine level is 2.8 or 3, then you can start alpha blocker, prazosin. First drug hypotension will be there. Ask the patient to take this tablet as the last tablet and don't move after taking the prazosin initial days for at least 1 to 2 hours to avoid the first drug hypotension and the fall. Okay. So these are the very common. So the resistant hypertension, the definition is the patient is not under your target blood pressure in spite of the 3 antihypertensive medications and 1 drug must be a diuretic. So that is a resistant hypertension. See the beta blockers. Usually we don't give the beta blocker as a initial drug of the choice in the uncomplicated hypertension individuals. Once the diabetes is, once the hypertension is complicated with the ischemic events, like see the beta blockers with heart failure. Do you use beta blockers or not? Yes or no? Yes. We have the 4 pillars in the management of the heart failure. What are they? 4 pillars. One is ARNI. Second one is, yes, SGLT inhibitors are mineralocorticoid receptor antagonists, beta blockers. Which beta blockers? Do you use propranolol or atenolol? Cardioselective beta blockers. So like bisoprolol, carvedilol, etc. Okay. So these heart failure. Then the angina. Yes, you have to use the beta blockers. How it helps in angina? To reduce your heart rate. Once you reduce your heart rate, your oxygen demand will be reduced. And then in post-MI, very common. If you see the cardiac ICUs, most of the people will have the ramipril, your Cardace 1.25 or 2.5 mg, and your Metexel 12.5 or 25. Very common drugs, 2 drugs, very common in post-MI. So the beta blockers are a must there. And post CABG, post PTCA, again a beta blocker is a must. Atrial fibrillation, tachyarrhythmias, definitely a beta blocker is a must there. So these are the compelling indications to use the beta blockers. See, the majority of the hypertensive patients need combination therapy to achieve the BP goals. Name any studies. Most of the studies they need 2 drugs, some studies they need the 3 drugs, some studies they need the 4 drugs also. No study is happy with a single drug. So from tomorrow onwards, do you use monotherapy or combination therapy? Yes. That's what all these studies say that. See the cumulative CVD incidence by the BP groups. So what do you mean by the SDH? What is SDH? What is ISH? What is IDH? Balu, what is ISH? Isolated systolic hypertension. What is IDH? Isolated diastolic hypertension. What is SDH? Systolic and diastolic hypertension. Excellent. See here, you read here, 42% increased risk of major vascular events for every 10 millimeters rise in the SVP. See, even today, we people, physicians, we don't respect the blood pressure. If it is 160 by 90 or 150 by 90 or 140 by 90, we don't give much respect. Just 10 millimeters more than your normal. So what is the risk? Is it 5%? Is it 1%? Is it 2%? What is the risk? 42% vascular risk. For every 10 millimeters hike of your systolic blood pressure, they didn't mention here, and 5 millimeters rise of your diastolic blood pressure. So always aim for your target of 130 by 80. When the systolic is more than the 10, when the diastolic is more than the 5 of your target, so there is about a 42% vascular risk is there. See, these are the comorbidities. Hypertension and CKD, very common. All the nephrology cases, CKD, are hypertensives, unless otherwise contraindicated. See, the CKD hypertension presence in 87, not 87, maybe 97% of the CKD population, especially the Asian data. See the coronary artery disease in the cardiology practice. 50 to 60% of the CAD patients have coexistent hypertension. 13% of hypertensives have the coronary artery disease. See the diabetes, deadly duo. Coexistence is rising. Diabetes have 1.5 to 2 times higher hypertension prevalence versus the non-diabetics. Then see the heart failure. Hypertension is a major upstream driving across all the ejection fractions. Whether it is a REF, whether it is a PEF, whether it is a mid-range, or PEF or EF improving heart failure, you have the hypertension as a comorbidity. So for hypertension, there are the 3 important reasons to cause hypertension in Indian population. 3 risk factors. What are they? Final years. 3 major risk factors for heart failure. Good. Hypertension, diabetes. Metabolic syndrome is a part and parcel of hypertension and diabetes. Dyslipidemia, no. That also comes under metabolic syndrome. Number 1 reason for heart failure in India. Of course, diabetes is there, hypertension is there. Number 1 is ischemic heart disease. Thanks to the cardiologists, they are responsible for heart failure cases. How they are responsible? They are making AMI people live for long period by giving primary PTCA, by doing multiple stents, by keeping CABG. They are making these people live for longer period and finally enter into a stage of heart failure. Okay? So in that way, we are very happy that cardiology, they are doing extremely good work in making all our AMI individuals to live for a longer period. Finally, at a later stage, because of your cardiac muscle dysfunction, your necrosis, and start losing its function, and finally enter into a stage of your systolic dysfunction or the diastolic dysfunction. How to detect the systolic dysfunction, systolic failure? What value will tell you whether the fellow is having the systolic failure or not? Good, ejection fraction. What is the normal ejection fraction? More than 50%. Okay. So what is the ref? Reduced ejection fraction? Less than 40%. More than 50%? PEF, preserved ejection fraction. Mid-range, 40 to 50. Okay. So what you mean by the diastolic failure? Diastolic heart failure? There is a very common, most common echo report nowadays. Whenever you see an echo report, echo says grade 1 diastolic dysfunction. A more than E. What is A? What is E? E means early filling. A means afterwards filling. Your ventricular filling. Ventricular filling defect is a diastolic dysfunction. Usually, most of the filling occurs in the early part of the diastole. Wherein the diastolic dysfunction, in the early part of the diastole, the ventricle will not fill. It takes a longer time. So afterwards, filling is more than the early filling of the ventricle, especially the left ventricle and the right ventricles. So that is called diastolic dysfunction. From tomorrow onwards, you see the echo reports. In most of the 90% of the echo reports, you can see diastolic dysfunction, grade 1, grade 2, grade 3, etc. You can see. So what you mean by the diastolic dysfunction? A more than E. E more than A, that is normal. Early filling is more than the afterwards filling, that is the normal. No diastolic dysfunction. Okay. So this is the things. So there is a big gap. So even today, so a lot of the gap is there. By protocols underperform the clinics. So monotherapy inertia. Missed phenotypes. Here the phenotypes. See the phenotypes here. The masked hypertension, nocturnal hypertension, non-dippers. These are due to low ABPM and HBPM penetration. What you mean by ABPM and HBPM, Balu? What is ABPM? What is HBPM? Ambulatory blood pressure monitoring, home blood pressure monitoring. Okay, so that is ABPM and HBPM. Now HBPM is not a big problem thanks to the COVID. Every house is having one BP apparatus and one glucometer, electronic BP apparatus. So with that you can know the blood pressure at home. That is home blood pressure monitoring. But ABPM, you need a machine. Okay, 24 hours they do the blood pressure monitoring. That is the ambulatory blood pressure monitoring. They charge for about 1500 rupees, 2000 rupees, 3000 rupees. Okay, so you know what is your blood pressure in the morning. You know what is your blood pressure in the afternoon. What is the blood pressure in the evening. What is your blood pressure in the night. What is the blood pressure before my talk. What is the blood pressure, your blood pressure after my talk, etc. You can know if you keep on getting the ABPM values. These are the very important, because now you have the 5 definitions of hypertension, not one definition of hypertension nowadays. So how to manage a complex patients? So correctly identify the patient, define the components of the CV risk profile, that is very important, manage the significant risk factors, individualize the treatment profile. So these are guidelines. What I am saying you, the guidelines, they are all are there to guide you, but the treatment must be individualized. So need for a comprehensive tool for the treating hypertension phenotypes and comorbidity. Management is complicated by the diverse phenotypes, sustained normotension. That means the BP is normal in the chamber, outside the chamber, daytime, nighttime, etc. etc. Masked hypertension. What do you mean by masked hypertension? They are normotensive in front of you in the chambers, but they are hypertensive outside the chamber, at home, maybe because of the spouse factor, maybe because of the SON factor, maybe because of the daughter factors, maybe in-laws factors, etc. They are hypertensive at home, but they are normotensive in the chamber. Nocturnal hypertension. This is also very common. What is the normal blood pressure during the sleep? Right? Good, 120/70. When your BP is more than 120/70 during the sleep, you are an hypertensive. I told you the 5 definitions of hypertension. One, you know that. One is your office blood pressure, 140/90. Now the second one is nocturnal blood pressure. During the sleep, if your BP is more than 120 systolic and more than 70 diastolic, you are normotensive or hypertensive? Hypertensive. See the frequent coexistence of the comorbidities, diabetes, dyslipidemia and obesity. So these comorbidities often remain undiagnosed, delaying the effective interventions. So one size fits all is not there in hypertension. Hypertension management must adopt the patient-centered approach. Therapeutic wheel. So this is the multi-specialty consensus on individualized treatment strategies for hypertension phenotypes and the comorbidities. What is the symbol? Emblem. What is that emblem? Our emblem. Association of Physicians of India. So these are the different doctors, pan-India doctors, great doctors. That includes your nephrologists, cardiologists, physicians, etc. So what is the finally they say? See the Gurpreet Vander, he is a Padma Shri and Padma Bhushan awardee. He is a cardiologist from Punjab. See Kamlesh Tiwari, he is from Lucknow. Muruganathan, he is from Tirupur. So Vara, he is from SGPGI. Girish Mathur from Delhi. See Meenakshi Sundaram from Chennai. See like that, okay. So a lot of the good people are there involved in this. They say that hypertension still remains a leading contributor to the global morbidity and the mortality. So it is our duty to make them not a leading contributor. Okay. Often coexisting with the major comorbidities such as diabetes, CKD, CAD, heart failure and obesity. In India, a significant proportion of hypertensive individuals remain undiagnosed. Even this era, with BMWs or BYDs or your Android phones, etc. and etc., still most of the hypertensives in India remain undiagnosed. We are doing a lot of harm to the society by not diagnosing the hypertensives. Okay, remain undiagnosed or inadequately treated, undertreated or untreated. So this is a big remarks from our Indian data. So it is our duty to detect the hypertension, make them diagnose it as an hypertensive, keep them on treatment, not under treatment, on good treatment. Not untreated, but on treatment. Okay, so this is the very important. By promoting a holistic approach, patient-centered approach, this consensus aims to bridge the gaps in clinical practice between you and me and standardize the management of hypertension in diverse healthcare settings. So that is my motto, to make you all as a good hypertensionologists, not only as a physicians but also as hypertensionologists. Who is hypertensionologist? Who detects the hypertension? Who diagnoses the hypertension? Who starts the treatment for the hypertension? Who make them on target blood pressure, your goal blood pressure? He is a good hypertensionologist. So aim for the consensus to provide the comprehensive guidance on the management, phenotype, already I told you. Okay, focus on the personalized and patient-centered. Now we move on to the methods. Yes, these are the 5 definitions of your hypertension. See, one is the office. So what is office? You know that, in the chamber, 140/90. See, this is the home. When the balu is at home, your blood pressure should be at how much your balu? At home. See, value. At home, 135/85. If it is more than 136/86, you are hypertensive. You are hypertensive at home. Okay. So your blood pressure at home should be less than 135/85. So this is the second definition. And the third definition, your ambulatory blood pressure monitoring, daytime, same as your home blood pressure, 135/85. That is your third definition. The fourth one, nighttime, or finally well said, systolic more than 120, diastolic more than 70. Okay, so these are nocturnal hypertension. During a sleep, your blood pressure should be less than 120 systolic and less than 70. See whatever the 24 hours mean, either day or night, your blood pressure should be less than 130 by 80. So these are the 5 definitions of hypertension. Office blood pressure, home blood pressure, 24-hour ambulatory blood pressure, nocturnal blood pressure, and the daytime blood pressure. So these are the controlled hypertension, masked hypertension, etc., nocturnal hypertension, etc. See the white coat hypertension. In the office blood pressure, high or low? Whatever the home blood pressure, normal. That is your white coat hypertension. Very fortunate population. You don't get any hypertension related complications in them. But I am worried about masked hypertension. How much? 5 to 10% of the individuals. Very high number. Very high number. So they are normal in front of you, but they are hypertensive at the home. So how to detect? Suppose your ECG shows LVH. Do you have a clue? Why should this LVH without an hypertension? Okay. So this fellow is having proteinuria. Creatinine level is normal. Proteinuria is there. Why should he have proteinuria? In the absence of diabetes. Could be hypertension. He is having creatinine level, maybe 1.6 or 1.8, but his diabetes is normal. Why should he have a elevated creatinine level in the absence of the diabetes with a normal blood pressure? So it could be a masked hypertension. You see the retina had the grade 1 or the grade 2 or the grade 3 hypertensive retinopathy, asymptomatic. Vision is the normal, 6 by 6, etc. But why should he have with a normal blood pressure in front of you? Could be having a masked hypertension. Okay. So early morning, occipital headache. Not the frontal headache. Occipital headache in the morning times, early morning. It could be because of your elevated blood pressure, masked hypertension. So these are the clues. Then you order your ABPM. Then you can pick up it. Otherwise, all the people sitting in front of with a normal blood pressure, if you keep on ordering ABPM, so waste of the resources. His BP is sitting before you is normal. His diabetes no, sugar is normal. His potassium level is normal. Creatinine level is normal. Urine protein nil. Fundus examination is the normal, and his ideal body weight. So not required. He is a normal individual without any hypertensive change. This is the very important. Sustained hypertension. That's what most of our people. They are high in the office. They are very, very high at home. Okay. So true normotension means here the normal, there also the normal. So uncomplicated hypertension. So but means uncomplicated means very few people. Uncomplicated means hypertension without diabetes, without dyslipidemia, without obesity, or without CKD, without CAD, without heart failure, etc. So first line ARB, either SCCB or the diuretic, then all the three, then you can add the third drug. So this is the one. So this is the comorbidities. See hypertension with CKD, with CAD, with heart failure, with dyslipidemia, with obesity, with stroke, with tachycardia, with diabetes. But that finishes my talk, I think. So diabetes and hypertension, diabetes and CKD, diabetes and coronary artery disease, diabetes and heart failure, diabetes and dyslipidemia, diabetes and obesity, diabetes and stroke, diabetes and tachycardia. See, coming to the respiratory disorders. COPD is very common. The hypertension and asthma is very common. Hypertension and obstructive sleep apnea. What are the first line of the drugs? In COPD, calcium channel blockers. Your ACE and ARBs, what is the common side effect? COPD. So, the best drug is calcium channel blocker. In the same way in the asthma, calcium channel blocker. In the obstructive sleep apnea, you can use ACE and ARBs or the diuretics, etc. Young individuals, young adults, still you can use ACE and ARBs and then not the calcium channel blockers, then the beta blockers because of sympathetic overactivity. So the Indians are having more sympathetic overactivity and young hypertensives are very common in Indian population. So in young individuals you can straight away go for telmisartan plus your bisoprolol, conquer T, etc. Okay. So this case, breathlessness and exertion for 2 months, ankle swelling. History of the present illness, 63-year-old retired teacher with a 10-year hypertension, progressive dyspnea, previously hospitalized for acute heart failure 6 months ago. Acute heart failure 6 months ago. Since then, on ramipril and loop diuretic. BP at home, blood pressure 145/90. Is it normal? Abnormal, not on target. As usual, most of our Indians, hypertension is at higher level only. So what is the treatment? No diabetes, no CKD, ramipril is getting, furosemide, the loop diuretic is getting, digoxin is getting. So what is the working diagnosis here? Hypertension with heart failure. Hypertension with heart failure, already admitted with heart failure 6 months ago. Now again readmission required. Again getting breathlessness and exertion and ankle swelling, pedal edema. What are the features of the heart failure? Pedal edema, elevated JVP, breathlessness, orthopnea, PND, hepatomegaly, hepatojugular reflex, asthenia, okay, polyuria. So these are the common symptoms of the heart failure. So he is in heart failure again. So frequent admissions for the heart failure is very common. Okay, okay. Now the diagnosis is hypertension and heart failure. Good. So this is the clinical examination. Vitals. Any abnormality here? So abnormals here are hypertensive range, blood pressure, EF is reduced, and the third one is echo, LVH is shown. So always keep the heart rate less than 90. Once the heart rate is more than 90, you respect, because the people with heart rate more than 90, they die prematurely. Okay, so don't wait till they reach a stage of your bookish tachycardia more than the 100. More than the 90, you have to give respect. So that is the most important point here. Now, which drug class forms the cornerstone in the hypertension? Reduce ejection fraction with hypertension. Here, okay? Oh, you are right. So number 1, A is the right answer. Number 2, when mild edema persists despite ARNI plus beta blocker, what is your next logical add-on? A is the right answer, MRA. Number 3, third question. If BP falls to 108/70 after ARNI initiation, what is your next action? Continue with right answer. Give him a big hand. Good, good, good. So, in spite of your ARNI therapy, if the BP falls to 108/70, don't stop it. You will get a lot of the benefits with ARNI therapy in the heart failure. You wait till systolic touches 100. Okay? So, continue with ARNI with the close monitoring. What do you mean by close monitoring? Suppose if you started on the 50 milligrams, make it 25 mg. If you started on 100 milligrams, make it 50 milligrams. But don't stop it. Next case, headache, blurring of the vision, 2 weeks. 55-year-old office worker, type 2 diabetes for 8 years. Blood pressure 150/90, despite amlodipine 5 milligrams. Occasional nocturia, tingling of the feet. Metformin 1 gram BD, clemiparate 2 milligrams OD. No history of ischemic heart disease, CKD, non-smoker. What is the working diagnosis? Why the tingling feet in a diabetic? Peripheral neuropathy. You name that. Peripheral neuropathy. Nice. Now why headache and blurring of the vision? So is the hypertension is the reason at 150 and 90? Not so. Most of these BPs are asymptomatics. Once your BP is more than 200 or 240, then they are the symptomatic. Most of the BP at 150/60, 90 usually asymptomatic. Why headache and the blurring vision? This is causing your headache. Amlodipine, side effects. What are the side effects of the amlodipine? Pedal edema, headache, vasodilator. Okay? Reflex tachycardia. These 3 are the side effects of your amlodipine. So change the doctor, change the prescription. So what drug you are supposed to start here? ACE or ARB, ACE or ARB. So sit down. Next one, any abnormality here? Good. HbA1c 7.8, not under good control. What is the average HbA1c of Indian diabetics? 9.4. But what is our target? 6 or 6.5 in this age group. See, what is the age? 55. So he should live for nearly 85 to 90 years. So he has to live for another 30 years, 35 years. So is it possible with HbA1c 7.8 to live such period? No. We have to keep the HbA1c at 6 or 6.5. Good. Next one, any abnormalities in these values? What? Yes, he is an hypertensive. Anything else? Peripheral neuropathy is there. Diabetic, hypertensive, obese. No peripheral neuropathy. Good. Microalbuminuria. What is your microalbuminuria? Normal, less than 30. What is here? 45. So microalbuminuria means diabetic nephropathy. So diabetic neuropathy, diabetic nephropathy. This headache and blurring vision could be because of the retinopathy also, because the nephropathy and retinopathy are good friends. Okay. Then what about other abnormality? LDL. What is LDL? Normal LDL. All the diabetics and hypertensives, what is your target? 50 or 35 or 70. A simple diabetic, 70. A complicated diabetic, 50. And post-CABG, post-PTCA, 35. So what is your target here? In a diabetic, hypertensive, obesity, neuropathy, nephropathy, your target should be either 50 or less than the 50. So what is the target here? What is the value here? LDL. Okay, yes, what treatment you are prescribing to this patient? So you have to control the blood pressure very effectively, but to control the diabetes very effectively, you have to use statins. What statin you use? What dose you use? Atorvastatin. Rosuvastatin, not atorvastatin. Rosuvastatin scores over the atorvastatin. Okay, what is the dose? Use minimum 20 milligrams of the rosuvastatin or 40 milligrams of the rosuvastatin. Okay, I stop here. Okay. Anyone? Am I clear? Okay. Thank you.